Most of what I talk, let me run through these first slides for a minute here. Okay, I have no disclosures. The need is that changes in breast cancer management are rapidly evolving, as you'll, I hope appreciate. Clinical decisions can be complex. Objectives are to identify multiple targets for which effective therapies are available for patients with breast cancer, identify possibilities for clinical trials, and understand the role and the timing for next generation sequencing for treatment of breast cancer. NGS has a more limited role in breast cancer than in some other cancers because we have so many other things available in breast cancer. So the outcome is to improve clinical decision-making for patients with breast cancer, respecting the range of variation and natural history of different breast cancers, patients' preferences, performance status, interest in clinical trial options, and so on. So the story of breast cancer has been going on for a long time. I mean, it just started out that we knew that there was ductal and lobular breast cancer and a couple of other uncommon types. And then clinical subtypes emerged with the hormone receptor and HER2. And then about 16 or 17 years ago, we became aware that breast cancer is really not one disease, it's like a half a dozen diseases. Luminal A, luminal B, HER2 enriched, normal, and so on. And now when we have genomics, we realize is that these breast cancers really have very myriad profiles. And this is what we're dealing with, like in all other cancers. So targets in breast cancer is not a short list. I mean, the first one was estrogen receptor and then HER2, but we're going to talk just a few minutes about cyclin-dependent kinases, mTOR, the androgen receptor, PARP in breast cancer, AKT PI3 kinase, MSI, and immune therapy against PD-L1, so on. So it's quite a list of targets. So the story of breast cancer as a target, really, this is Bill McGuire's paper from the Journal of Clinical Investigation in 1973, estrogen receptors in human breast cancer. And in this paper, he showed that you could measure estrogen receptor in femtomoles per milligram of cytosol protein. A femtomole is a millionth of a billionth of a mole, okay? And that correlated with the with binding to the receptor of tritiated estradiol. And the first drug that worked for breast cancer as a targeted therapy was not tamoxifen, it was diethylstilbestrol, estrogen. And when tamoxifen was introduced, it was put up against DES and worked as well, not better, as well as estrogen, but with less side effects. So that's how tamoxifen initially got approved for metastatic breast cancer. And over time, we've seen that adjuvant tamoxifen therapy for even 5 years has a marked improvement in postmenopausal women with a gain in disease-free survival and recurrence of 17% and a 10% improvement of survival in postmenopausal women. And in premenopausal women, it works as well, 12% improvement in disease-free survival and a 10% improvement in overall survival when you get out to 15 years. So that was the first big impact in breast cancer. And over time, you know, we went from tamoxifen to aromatase inhibitors to Fulvestrant, which is targets the estrogen receptor, but also downregulates the estrogen receptor. And then the mTOR inhibitor everolimus was approved. And then the CDK inhibitors have been approved, and now also a PARP inhibitor. So we've got all of these things in ER-positive breast cancer. These are all drugs that work in hormone receptor-positive breast cancer. Even we used to use androgen therapy all the time and progestins all the time. They're still available. What I'm not going to talk about in this talk, I'm not going to talk about HER2 amplified breast cancer, and I'm not going to talk about like the genomic molecular testing that we use in early stage breast cancer to decide whether to use chemotherapy or just hormone therapy and stuff like that. That's all pretty familiar. So one of the things that came up is that when breast cancer progresses on a non-steroidal aromatase inhibitor like an anastrozole or letrozole, then we know that some of those will respond to exemestane as a steroidal aromatase inhibitor, just switching to a different kind of aromatase inhibitor, or to use the estrogen receptor downregulator fulvestrant. And so the SOPHIA trial was to compare those two options, and basically they were the same. But one of the things that was appreciated in the SOPHIA trial is that if you test metastatic breast cancer, one of the mutations that's very different from primary breast cancer and metastatic breast cancer, this is primary breast cancer, is the gray bars, is that about 20% of metastatic breast cancers that have seen an aromatase inhibitor before have a mutation in ESR1. And basically what that mutation does is it makes the receptor active regardless of whether it has estrogen. So it doesn't help to use an aromatase inhibitor or something to block the receptor. You need to have another plan. And in the SOPHIA trial, if you look at the ESR1 mutated breast cancers, the estrogen down regulator works better than switching to another aromatase inhibitor. But in the wild type, they're pretty much the same. So that was the first clue about an actual mutation in a receptor that actually was clinically relevant. And we're very familiar with these kind of pathways. There are many pathways of endocrine resistance in breast cancer. There are upstream signaling through growth factor receptors like HER2, EGFR, and so on. Then there are also increased signaling through the PI3 kinase pathway. So there's a number of things, and down the bottom of this pathway is mTOR. And one of the drugs that was approved for mTOR, of course, was the mTOR inhibitor everolimus. And this shows fulvestrant, which is a good second-line regimen, especially if there's a ESR1 mutation. But when you add everolimus to it, it improves the outcome over, this is a placebo control with fulvestrant plus or minus everolimus. But that was true until about 3 years ago. And then this whole story came about. And in hormone receptor positive breast cancer, hormones work primarily, maybe not entirely, but primarily because they're cytostatic, and that's why you have to take them so long. You have to wait, suppress they're not cytocidal like chemotherapy drugs, and you have to just stop the cell from dividing and wait for apoptosis. That's why it takes so long. That's why you have to be on so long. But, cyclin-dependent kinase takes up cyclin, D-type cyclins. And what that does is phosphorylates the RB protein, which drives cell cycling. So if you could block cyclin-dependent kinase with a CDK4/6 inhibitor, then you could stop the phosphorylation of RB protein and then basically put the cell into G1 cytostatic or even G0. So that's the simple explanation about this. And now there are 3 of these approved by the FDA. The first one, palbociclib, for metastatic breast cancer a couple of years ago, and just in the last 8 months, these other 2, ribociclib and abemaciclib. So I'm going to go over these to just put out a couple points. So first study, the PALOMA-1 study, actually had 2 cohorts, one with the more restricted populations to see if it made any difference. And they found it didn't make any difference, so they analyzed it all together. This was a small study, altogether about 150 patients, phase 2. And it was first-line therapy of metastatic breast cancer with letrozole, with or without palbociclib. And this was the improvement in progression-free survival, and this is what got the FDA to approve palbociclib for metastatic breast cancer, and improved the median progression-free survival from 10 months to 20 months by the addition of palbociclib, so we can block the cell cycling not only from the estrogen receptor point, but from the CDK 4 and 6 point as well. So double reason for blocking. But one of the reasons I also wanted to show this trial, because this is the first one, we have actually long enough follow-up on this trial to look at overall survival. And what you can see is that the overall survival is not that much different. And that's important to keep in the back of your mind when we use these agents. You know, what it does is delay the time that the patient needs to go on chemotherapy, and that's valuable, and that's why the FDA approves these based on disease-free survival. But we have to wait these other trials out and see, is there any impact actually on overall survival, which is what we'd really like to see in some case. So the PALOMA 2 trial was a bigger trial, and Mona Lisa is the trial that, tested ribociclib, PALOMA 2, palbociclib, and this is no prior treatment for advanced disease, but bigger numbers. And so it was palbo plus letrozole versus letrozole, ribo plus letrozole versus letrozole, and basically same outcome in a bigger patient population. The MONARCH trials are with abemaciclib, and this is no prior systemic therapy. Abemaciclib and anastrozole versus anastrozole, and same story. So all of these work about the same way. Now, one of the things when Dr. DeLeo presented this at the few months ago at the ESMO conference is he did I want to point this trial out for one reason, and that is patients who have indolent hormone receptor positive breast cancer, sometimes they do really well on hormones. And so does everybody really need to have these agents first line? If you go to some cancer centers, they just put everybody on a CDK4/6 inhibitor right off the bat as soon as they have metastatic breast cancer. But I told you about one of my patients yesterday who had metastatic breast cancer on hormone therapy for 28 years, and she didn't get any CDK4/6 inhibitors. And so one of the things that we've understood about breast cancer for a very long time, for decades, is that the longer the disease-free interval, since the patient was diagnosed with breast cancer before they show up with metastatic disease, the more likely it is to be exquisitely sensitive to hormone therapy. And it's probably because they have a lot of estrogen receptor. So Dr. DeLeo presented this data and showed that if the treatment-free interval was more than 3 years, this is the kind of difference you got in terms of adding abemaciclib. But if it was a shorter interval, so the disease is relapsing sooner, then you really saw that's where the impact is. So it's important to kind of keep this in, and not, I think we have to think about individualizing how we use these agents. And it may be that eventually everybody's going to get this, but I'm not sure that everybody needs it first line. That's my own thought about it. We should get more of this information with further follow-up on all of these other studies. So the MONARCH 2 study had, what about people who have already had first-line therapy for metastatic breast cancer, and then or it was not that, but they relapsed while they were still on adjuvant endocrine therapy or within a year. So this is more resistant. And this was, instead of giving them a aromatase inhibitor, then this was with Fulvestrant, give them the estrogen receptor down regulator with or without the CDK4 inhibitor. And you can see the clinical benefit rate here. This is placebo, and this is abemaciclib plus Fulvestrant, and you can see how many of these are down here, and these are the partial responses. So the clinical benefit rate here in the intent to treat population is 72% versus 56%. The PALOMA 3 study actually was patients who had progressed on prior endocrine therapy, so they were progressing on an AI or within 12 months of adjuvant therapy, and this is palbociclib with fulvestrant. Same story, 4 months versus 9.2 months. And let's go back to the issue about ESR1 mutations. Remember, fulvestrant worked better than exemestane if the patient had an ESR mutation. And they found a number of patients, all kinds of ESR1 mutations in the PALOMA 3 trial. And then they said, okay, what difference does it make if we use palbociclib in whether it has an ESR mutation or not? And the truth is, it works regardless. It helps. It adds to the disease-free survival. Of course, in the wild type, the curves are a little higher than they are here, but it particularly makes a big difference if there's an ESR mutated tumor, but it works either way. So that kind of takes that whole issue out of the equation. The last of these trials that I want to talk to about is, what about patients that have had a lot of prior treatment? And this is a single agent trial. This is MONARCH 1 with abemaciclib just by itself, no other hormone therapy or anything else, just daily. And this was a heavily pretreated population, 132 patients in each arm. I'm sorry, not in each arm, it's a single arm trial, 132 patients. And these, all of these patients had 3 or 4 prior regimens. 91% of them had taxanes. 73 of the 132 patients had capecitabine. So this is a heavily pretreated ER-positive population of cancer patients. So this is just by itself. And these are the responses with just this agent alone. And you can see that the clinical benefit rate here is about 42%. So it even works in very refractory, hormone refractory breast cancer that's already seen a lot of chemotherapy. So these are the schedules, and these are the main toxicities of them. And the 2 that I want to point out is the grade 3 and 4 toxicity with palbociclib is 54% in terms of neutropenia versus about 25 to 30% with the other 2 agents. On the other hand, abemaciclib has about 20% grade 3 or 4 diarrhea, whereas the other 2 agents are less. So side effect wise, if the patient doesn't tolerate one, there's other choices and so on. So how do we make this really impact breast cancer in the long run? And one of the trials that we have available to our patients at UK, we have several patients on this trial, is the palbociclib collaborative adjuvant study. This is a global study, but it's run through the NSABP in the US. And so these patients finish all their adjuvant therapy for hormone receptor positive, HER2 negative breast cancer. And then normally they would go on endocrine therapy. And so in this situation, they get endocrine therapy with or without palbociclib for 2 years. And we'll see if we can use this cytostatic CDK4/6 inhibitor, if that will actually reduce the recurrence of breast cancer. This may be where the payoff is, and this is why this trial, I mean, if I had a patient who had 8 positive nodes and was hormone receptor positive, I would want her to be on this trial, because this may change her future if it works, but we have to test it. Okay, right, what about other receptors? Well, the androgen receptor has been of interest too. I told you that we used androgens years ago to treat breast cancer. But what about blocking androgens? Well, here's Abiraterone. These are drugs that are used in prostate cancer all the time. Here's Enzalutamide and bicalutamide, and where they block in the androgen receptor pathway. Tiffany Traina just published this 3 weeks ago in JCO. She's been kind of leading this at Memorial and in collaboration with some other institutions. And they basically found they tested a lot of patients, and then they had 118 patients who had at least 1% androgen receptor expression in triple-negative breast cancer, okay, triple-negative breast cancer. But they also had a more concentrated group of patients who had at least 10% estrogen receptor positive, androgen receptor positive triple-negative breast cancer. And there were 78 in that with at least 10% AR positive. And what they found is that the clinical benefit rate at 16 weeks was 33 out of the 78 patients in the evaluable group. You can see most of the benefit in the intent to treat population was in the group that had more than 10% expression of androgen receptor. But even at 6 months, 22 out of 78 still had response or stable disease. And a few of those had documented PRs in triple-negative breast cancer just with an androgen receptor blocker. And this is the progression-free survival and the overall survival. What's interesting here is about 20% of the patients on this plot are still alive 3 years later with triple-negative breast cancer. So this needs more development, and this is in the cohort that had androgen receptor more than 10%. So this is a clue that there may be something here. Here's a different study that used Abiraterone, and this is just one case out of that. This is a patient who had skin recurrences and also some nodal and chest wall disease, and this is 4 years later. Here's the skin, the node is gone, the chest wall disease is gone, and so on. This is 4 years just in triple-negative breast cancer. So what is an actionable mutation? Let's talk about mutations the rest of this time. So to the researcher, this is from George Sledge and something that I read that he wrote. Actionable frequently means that a mutation X is associated with some badness, and that there's a drug for mutation X, and therefore mutation X is actionable. But it's also important to think about, what does the patient think about actionable? Actionable refers to identifying a drug that will prolong life and reduce suffering. And I think when we talk about actionable mutations with patients, we need to make it clear to them that this is really what we're interested in, is their perspective on actionable. And George's comment was, I would argue that the patient's view on actionable and is indeed a much more appropriate use of the word. And that's how we should frame it when we talk to patients. Okay, I'm going to skip this slide about PARP inhibitors because you know how PARP inhibitors work in a BRCA mutated setting. But the OlympiAD trial was a trial to test the PARP inhibitor olaparib. And this was in patients who had BRCA mutations, and they were suitable for first-line, second-line, or third-line chemotherapy. And they all had prior taxane therapy. And this is in triple-negative breast cancer, metastatic breast cancer. No, these are BRCA mutated, germline mutated patients with germline mutations. Not just triple negative, but also hormone receptor positive, HER2 negative. And they were randomized to the physician's choice of what they wanted to use next for their next line of chemotherapy. And these are typical next line chemotherapies that would be used in patients, for patients who had already seen taxanes and anthracyclines. Capecitabine, vinorelbine, eribulin, these are common choices versus olaparib. And this showed that the patients on olaparib did better than the patients on chemotherapy, with a median improvement in progression-free survival from 4 to 7 months. So you could delay chemotherapy in these patients. And here's the objective response, 60% versus 30%, and 9% complete responses with olaparib. There's all of these that are in clinical trials now. Olaparib is the first one to be approved by the FDA for metastatic breast cancer in the setting of germline BRCA mutation. Now, if you look at the Cancer Genome Atlas, they found 128 cancer-relevant genes in breast cancer. And a lot of these, have potential targets. One of the studies that I was kind of fascinated by was, it was one by Carlos Arteaga when he was over at Dandy. And what they did is they took triple-negative breast cancers who had received neoadjuvant therapy, and then they did molecular profiling on the residual disease that the patients had after they went to surgery following neoadjuvant chemotherapy in triple-negative breast cancer. And with NGS sequencing, then they found all of these mutations here. This sequencing didn't look for ESR1 mutations and stuff like that. One of the things I wanted to point out, though, is they found HER2 amplification in 7 of 81 patients in triple-negative breast cancer. This is amplification of HER2, not mutation of HER2. And this reminds me that when you do a biopsy and you're going to use neoadjuvant therapy, you really need to sample the tumor because it can be heterogeneous. There can be areas of the tumor that are HER2 positive, and you miss them if you just take one biopsy. We have one patient recently that we treated who had 6 cores of a 4-centimeter tumor. 5 of them for HER2 were stone cold negative, and the other one was 3+ and had a FISH ratio over 6. So these, so I'm not surprised that he found some of these triple-negative breast cancers that after neoadjuvant therapy, that HER2 amplification was probably there in the beginning, but it was missed because the tumor wasn't sampled adequately. So our radiologists who do our breast biopsies, they do several biopsies in different areas of the tumor. So they found all of these families, and there are potential targets for any one of these. And similar to a slide that Rachel showed, 90% of the patients had an aberration in at least one of these pathways. So let's not talk about HER2 amplification, but what about mutations? Well, these little pink dots are breast cancer, and this is from the Cancer Genome Atlas, and the red bars are amplification of HER2, but the green is mutations in HER2. So the Summit trial was a trial to look at neratinib, which, as we know, binds attaches to the internal domain of the HER molecule, and it's a pan-HER inhibitor, and it blocks ATP binding in the internal domain of the molecule. So they did this in a bunch of different types of cancer, and they found gain-of-function mutations in a lot of breast cancers. This is there. And this is the breast cancer cohort, and this is using neratinib in mutated HER2. Yet almost all of them had at least stable or decreased, and these are all partial responses by RECIST, and this is by PET SUV units, a couple of them with 100% complete eradication of PET signal. Now here's just an example of something a little more in detail. Sometimes you have to think more than one target at a time. So these blue bars, this is in wild type, and this is in 3 different mutated cell lines. And if you use, in HER2 mutated cell lines, if you use Fulvestrant in the ER positive HER2 mutated cell line, you get some reduction from the wild type. The blue lines or if you use neratinib in the cell lines. And these little boxes down here, these little orange ones, this is if you combine neratinib and fulvestrant. Okay, so here's a case to demonstrate that. This is a woman who was diagnosed with ER-positive, HER2-negative breast cancer in 2010, had a chest wall recurrence, developed bone mets, and then developed skin mets, and had next-generation sequencing, and was found to have a mutation in HER2, a mutation. And then she went on the Summit trial, and she went on the Summit trial in December, and a month later, this is the difference in her disease on her chest wall in 4 weeks, okay? From December to January. And then the tumor started growing again and progressing. And then instead of stopping the neratinib, just added the ER downregulator, fulvestrant. And then you can see that this is where she progressed on the chest wall. That went away. Here's a mass here in the chest wall. That went away by hitting both targets simultaneously. So we have to think a little bit outside the box. Now, what about PIK3CA? This is just about prognosis with PIK3CA. It's all over whether mutant is better or wild type is better. It probably doesn't do that, but the question is, what about PIK3CA as a target? So here is a trial using paclitaxel plus or minus I have to practice this, ipatasertib. Okay, say that 6 times quickly. And this is an inhibitor for PI3 kinase with abnormalities by NGS sequencing in the PIK3CA AKT pathway. And this is paclitaxel plus placebo, and this is paclitaxel plus the PIK3CA kinase inhibitor. So this is another this is an AKT inhibitor, another one, and this looks at the prevalence of this particular AKT mutation for this trial, and it was to use this drug AZD5363, and they did it across a whole bunch of different types of cancer. About 2% of breast cancers had this, and then they accrued 20 patients in breast, GYN, and then other solid tumors. And these are the responses in breast cancer here. This is GYN, and this is other. And again, activity by targeting the AK3 pathway. This is one patient. And they also found out that if you do cell-free tumor DNA in the blood, that it declined, the mutation detection declined in 21 of 22 patients. But if the decline was persistent for more than 3 weeks, then you got a better response than if it just dropped transiently. And here's one patient that had a persistent response. This was her CAT scan. And this is 8 weeks later, and there is the mutation in her blood. So pretty dramatic response is possible. And lastly, I want to just say that, you know, in the study that we've all been aware of, where pembrolizumab has been approved for microsatellite instability, 2 of the patients in that trial had breast cancer, and both of them responded, one for 7.5 months, one for 16 months with pembrolizumab. And if you look at triple negative breast cancer, in one study that screened patients with triple negative breast cancer, almost 60% of the patients had PD-L1 expression, at least 1%. So another trial that we are currently doing here is through SWOG, and basically this is patients with triple negative breast cancer who get neoadjuvant therapy, and then have residual disease. So they have at least 1 centimeter of residual disease at the time of surgery, or they still have cancer in at least 1 lymph node. So if it's like microscopic or 5 millimeters of residual disease, clean nodes, then that doesn't count for this trial. But if they have residual disease in the breast or in any lymph nodes, more than 1 centimeter in the breast, then they get registered, and we send the slides of the tumor centrally to the center. And when they know that they can do PD-L1 testing on the slides, then pretty quick turnaround time, then they randomize the patients to receive either observation or to use pembrolizumab every 3 weeks for a year in triple-negative breast cancer. This is a sensible, again, target. I think the more we can get the more we get some clues in metastatic disease, but quickly move it to adjuvant therapy, that's when we're going to change triple-negative breast cancer. Because we all know that advanced triple-negative breast cancer, even if you get a little signal, patients don't live long. If you really want to change triple-negative breast cancer, you've got to do it up front. So this is a worthwhile trial. We have several patients that are enrolled in this trial now, and that's available. For oncologists who want to give adjuvant capecitabine based on the trial from Japan, which is now approved for extended therapy, then that is allowed now in this protocol. But this is a worthwhile option as well. So to tie this up, breast cancer is a heterogeneous disease. I would argue that it isn't a disease. It's many diseases. Targeted therapy has been a large part of the story for over 40 years. Precision medicine has revolutionized cancer clinical trials and the drug approval process. At present, the NCCN and ASCO guidelines do not recommend next-generation sequencing of blood or tissue to direct metastatic breast cancer patient treatment. On the other hand, this may be entirely appropriate in 2 situations: for patients interested in clinical trial options and for those who have limited options with standard therapies. That's where it makes most sense. For many newer targeted therapies, there are data regarding improved disease-free survival, but as I showed you with the one longer-term follow-up with the CDK inhibitor, encouraging low toxicity, but little information about whether overall survival will be improved. We have to follow these trials out longer. The identification of key cancer drivers versus passengers with multiple somatic gene alterations remains a challenge, and clinical trial enrollment is the way to go here. So thanks for your attention. I appreciate your time.